That's a great segue into talking about the types of CINV, since we're all saying that this is something that occurs relatively quickly and is short-lived over the time after chemotherapy. So, Howard, can you talk about sort of the definitions that we use to determine CINV?
Absolutely. We try and divide it into various categories, and hopefully it leads to better treatments by knowing what category we're trying to deal with. So we talk about first acute versus delayed. And acute CINV defines the first 24 hours after the treatment. So if anything happens in terms of nausea, vomiting during those first 24 hours, we're saying that's the acute phase. From 2 days out after treatment, it becomes the delayed phase. Typically, we're talking 2 to 5 days is reasonable. So we're looking at those 4 days after the first day of treatment as being the delayed phase. Does a patient have delayed nausea, acute nausea, depending on their response to treatment? Next category is more functional, which is breakthrough. So here's a case where we've treated a patient what we think is appropriately to start with antiemetic therapy, and even in the course of that treatment, they still have nausea and vomiting. So this may be nausea, this may be vomiting, it may be a combination, but it's something that the treatment hasn't really taken care of. We call that breakthrough, and that could happen anywhere from day 1 through days 2 through 5, depending on the treatment we're looking at. And the last, which is really important, and I think Eric brought this up before, is anticipatory. Patients hear about chemotherapy and they expect to get nauseous. That's the expectation from the media. Faulty or not, it is. So here's a patient who walks in, and as soon as they see the office, they're already getting nauseous. Haven't treated them yet, but they anticipate the problem happening. So this is a smell, this is a sight, this is whatever it might be, and we have patients who walk in, and as soon as the nurse walks over to start their line, they're sick. Haven't done anything yet. So we have to really look at these different phases and different ways people have problems with nausea and vomiting and try and address all of them. And they're addressed differently in all these cases.
So Eric, why is it that acute and delayed are different? Where does that come from, and how do we get to that type of criteria?
So it's actually an artifact of our research. So we arbitrarily chose acute phase as the 24-hour window, and then anything past that is being delayed. And there's multiple observations from this. The acute, we actually do a pretty good job of controlling nausea and vomiting, which is great because patients come into the infusion center, we think they look good, they leave, and we think all is well. But the delayed phase is really where the challenge has been. And I've even introduced a new category. So we have acute, delayed, breakthrough, but we also should consider what we're calling either refractory or chronic nausea, that despite all these things, despite medications in the breakthrough setting, people are still having symptoms, and especially low-grade nausea.
So that can occur from therapy, and particularly it was mentioned about oral therapies. So there are some oral therapies, and we have a lot of new oral therapies now that can cause moderate metagenicity, or at least nausea, and that's a difficult problem in terms of how we address that with antiemetics. I do think it's worth noting, though, that generally, wouldn't you say that after about a week, if patients have received intravenous chemotherapy, we should really think about a different cause of nausea and vomiting? And there's many causes from cancer patients. If they have GI motility problems, or brain metastases, or renal insufficiency, or other things. So it's always worth looking, particularly after you're out of that period of risk for most patients.
Yeah, stop and think is the key there. Yeah, what else is going on?
Which is a good thing to do when you're taking care of patients, no matter what. So, period.
That, and it's obviously tricky because we traditionally believe that acute nausea is more mediated by serotonin, versus delayed nausea can be a combination of multiple different neurotransmitters involved, and that's what I think makes it more difficult for us to deal with the delayed phase, not to mention that the patient's not in front of us actively. So there's a couple different factors that make that probably more complicated in the area of CINV.
And the original reference drug that was the cornerstone of the way we developed all this was cisplatin, which has a well-known biphasic kind of mechanism, or response, I should say, about nausea and vomiting, with a high acute and also a delayed. So it occurs for both, but as you say, maybe triggering different receptors. And we're going to talk about a little later about our approaches, which really address those and the different neurotransmitters and the way that we can block those effects, which are normal physiologic effects if you have a toxin ingested or introduced into your body.